Welcome back to the next Psychiatry Power Hour. First thing is a little quiz. What do these two pictures mean when put together? We have a cat, and I'm told that's a tonic. That's right, catatonia. So we're going to talk about the diagnosis of catatonia and treatment. Sorry, that's a terrible joke. So I'm going to kind of run through the workup, diagnosis, treatment concepts. So initial workup, let me get myself in the picture so you can pretend I exist. There we go. All right, so step one, rule out NMS, neuroleptic malignant syndrome. This is potentially fatal, autonomic instability, heart attack, death kind of thing. So NMS is basically they have to be on a dopamine drug. No dopamine drug, no NMS. It can be either currently on it or withdrawal. The weird classic case for withdrawal is actually a person who's been on clozapine for a long time. You take it off, they stop moving, they lock up, and you give them clozapine back, and then they can move again. The more normative case is basically you put a person on dopamine drugs in the last week or two, and then they start to have what eventually becomes NMS. Early stages of NMS can look exactly the same as catatonia. There's no way, honestly, you should or could tell the difference. Once you get well within NMS and it's got the presenting primary symptoms, you get rigidity, mutism, stupor. So that's a rigid, locked up person who won't respond to you. So we use the DSM diagnosis because we're people who are going by the DSM. We're in psychiatry, so it's a symptom list from criteria A. We'll talk about on the next slide. You need at least 3 symptoms. There's common major risk factors for getting catatonia. That is delirium, you can have it, schizophrenia, mood disorder, which basically is everything. It's anxiety, depression, bipolar mood disorder, it doesn't matter. And autism is a special case for severe autistic folks. We're not going to really talk about that one too much in this presentation. And then you need to do a safety evaluation, and we'll talk about that towards the end of this, about things you should make sure you do so that they don't get hurt and that the primary team might not be aware of. So this is the criteria that's used by the DSM. We use 3 symptoms, 3 or more. I read a case, a paper that was a couple of consult liaison doctors, and they had a 220 person series they did over like 10 years or something. And they said basically they prefer 4 symptoms actually because the specificity is roughly 100% at that point. It's a lot of terms, and the terms can be a little weird sounding or confusing. Let me move this down. And part of the reason is that this process was originally kind of looked at starting in the 1880s with severe effort with Kraepelin, then Kalbaum and Buehler and all them, Bleuler, however you say their names. And some of the terms are actually a lot of them are from that time frame, from like Kalbaum. Basically, there's this long-running diagnostic argument where people know that there's verbal components and motor components, and there's actually more than one way with different terms. Like if you look at the questionnaire sets when they're doing screening or kind of monitoring, they actually don't use this exact word set, and that's just because it's not, even though it feels real standard, we have a book, we go by it in psychiatry, but it's not really standard, or at least it's argued. The verbal components, assuming it's not just stupor, which is probably the most common version of catatonia, which is unresponsive to nearly all external stimuli except for like sternal rubbing them, and they just kind of move. So the verbal components are usually mutism and echolalia. Mutism just it goes right along with stupor. Verbally unresponsive or minimally responsive. Echolalia is the mimicking involuntarily of another person's speech. It can be immediate or delayed, so it doesn't matter if it takes 5 or 10 seconds. A key component to that idea, which is like involuntary mimicking, is all of catatonic symptoms are involuntary. So don't think of it as purposeful movements or actions or words. Everything they're doing is, even like the agitation, it's not supposed to be influenced by the outside stimuli. This is unconsciously being done. It's not, realistically, when I say unconsciously, they're literally not working through the steps and as far as like frontal lobe activity. So echopraxia is the motor equivalent of saying echolalia, for lalia speech, praxia for movement, so it's involuntary mimicking of another person's movement. Catalepsy, classic old term, I'm pretty sure this is Kalbaum's, kind of doing. Rigidly remaining immobile posture despite the awkwardness or fatigue. I'm going to jump down too. So posturing, so catalepsy is just immobile. They're just sitting there. You walk in the room, nobody's done anything, and they're holding up posture of some sort. And if you see them spontaneously move and then they do something strange and hold, that's posturing. If you push their arm up and it's kind of like there's a little bit of resistance and then they just let you move them like wax, it's a little bit of resistance but not too much, that is waxy flexibility. They'll do stereotypy, which is like repetitive, non-goal directed activity, marching in place, sitting and standing, walking back and forth, that kind of thing. But they're walking back and forth, make sure they're not on, like aripiprazole, 30 milligrams all of a sudden, and they're just akathisia. Sorry. And then we got mannerism, odd, purposeful movements, keep unbuttoning and, unbuttoning and buttoning clothing over and over, something like that. Mannerism, it's supposed to be like a very complicated normal movements, but it's odd, doesn't really look like it makes any sense. If you feel like this is a lot of degrees of nothingness, that's probably why. You're just do your best in trying to make the distinction. I kind of took this terminology as a split from the DSM and then what the question sets actually say. If you do what the research was done, that half the stuff is really based on. This is the kind of wording that is from. Negativism is one that some doctors like to really point out and think it's amazing. So there's this thing where some people, when they're catatonic, again, they're not thinking about what they're doing, they're not trying to be mean, they're not doing stuff, where they basically will not do what you say. They'll do the opposite. So it's kind of like you say, hold your hand there, and then they pull it back, or, push up on my hand, and then they try to pull down on your hand, or whatever. That they're literally doing the opposite of what you're asking, and it seems like they're being a jerk or something, but they're not. They're catatonic. Stupor, like I said, most common situation. We just walk in, you can't tell if it's like hypoactive, hypoalert, delirium. They're just not moving. Agitation, not influenced by external stimuli, and then grimacing. So just like muscles in their face all locked up, or if they're just looking mean, that kind of thing. So DSM, remember it's 3 at least. If you want to just be super accurate, you can go for 4. Basic workup. This is not like the official from brought down from above setup. Nobody will agree on what you should do exactly. Nobody. There's no standard treatment protocols. There's no standard lab workup. To some degree, you might be almost doing an altered mental status workup, to be honest. But from my point of view, this is kind of what I would do. I think you should do your vital signs Q4 initially, because you really want to start looking for autonomic instability, and which could be their heart rate sitting at 110 and they're 70, and that sucks and looks scary. You don't want them to tire out. And then once you think they're kind of doing okay after a day or 2 or 3, maybe drop it to Q8. I think this matters. Like, I had a patient just recently that I'm pretty sure what happened was looks like delirium. Then a day later, it's obvious it's catatonia. It was done through telemedicine. It was really hard. I couldn't do a normal exam, unfortunately. And got them looked at, weren't being followed super close, and I think they basically ended up with an arrhythmia of their heart, because they went to the ICU from the vital signs not being monitored close enough, and that kind of setup. You should do an MRI brain with or without contrast, because you kind of need to do a stroke lookup, right? If someone just locks up, or they're not moving something, or they look like they're doing weird stuff. If it's really just kind of started and it looks like it lasts for 5 minutes and then it kind of stops and it comes back again, I mean, it could be like a non-convulsive status epilepticus kind of thing, which would be pretty scary in that situation. You got to get that taken care of really quickly. I think some labs you should just kind of do routinely every day for a little bit until you feel like they're safe, which maybe just 2 or 3 days. You're not like 10 days, but CBC, kind of making sure they don't get infections or something going on, or really messed up electrolytes, because nutrition and stuff are a pain, and when people are just like stuporous. CMP, basically, if you need to do that at the beginning, and because everything on that panel, just about, if it's out of whack enough, would actually cause people to have bizarre behavior. TSH just one time. Make sure they're, it doesn't say it's like 900 and they have zero the thyroid hormone being made or something. Or if it's super high and they're acting crazy and agitated, you're like, well, that's why. The TSH would be low, but the thyroid being high, that is, for hyperthyroidism or thyroid storm. UA, do it at the beginning, and if they're kind of incontinent, it takes a little while to take care of. Maybe you want to try to do it periodically because UTI is a real thing. Nosocomial infections in hospitals are no fun. And if they're rigid or if they just continuously move the whole time over and over and over, rhabdo, because you get rhabdo from not moving, lying down on a hard surface being the most common version, right? It's your 75-year-old passes out, they're in their apartment, somebody finds them a day later and they have a lot of rhabdo because they've been sitting on the ground not moving. The other thing is they're the whole marathon runner moving, and rhabdo. So that's that. So the stroke thing that would, if a person stops moving and doesn't do anything, there's a locked-in syndrome, super rare. It's a ventral pontine infarct. So you're just looking for any kind of basic stroke in that area where you have a part that lights up appropriately on MRI with contrast. That's the scary thing, person where they can blink their eyes, and that's basically it. And it's like the worst looking thing ever, and probably the worst thing you'd ever do to a human. So they have preserved eye movement. That's all you get out of it, and their consciousness, but they can't move or talk or anything else. So general information on the treatment of catatonia. So step 1, you got to stop all the antipsychotics. It's an NMS rollout and for just general safety in that situation. Treatment goals are symptom reduction within hours to days. There are some of these things like a Bush-Francis catatonia rating scale. You just look it up. I don't know if I can show it. I think it's copyright. But it's really just asks the basic definitions of catatonia, and it's like 0, 1, 2, 3, 4, not present at all, sort of present all the time, and it's like you don't need a questionnaire set. So you'll do it once, maybe your first time, and then you'll feel ridiculous doing it as a psychiatrist. So you're just looking for symptom reduction, which could be I'm not moving, and now I'm moving a little bit, and I'm not locked up anymore. I'm at least kind of soft for the first day. That's it. You don't worry about, you give them the medicine and no, they're all great. Like if that happens, awesome. You're a superhero. Good job. But don't necessarily expect it or feel bad or something's going wrong. Typically, treatments are run 4 to 10 days. Most of the folks it's gonna be half a week to a week and a half before you get them to a safe place and they're talking and walking. The up-to-date kind of thing says continue the treatment, which is benzodiazepines, for 3 to 6 months after they leave the hospital. I don't think there's any real information, evidence, rationale for that. But basically, if you're the CNL person, you're always going to keep them on benzos and send them home. You're not going to be the one to stop it. So outpatient. But if you write 6 months, you're probably going to scare the outpatient psychiatrist. They're going to keep it running for a half year, and then you're going to be fighting a person who's got like tolerance and maybe addiction. So focus on the dangerous symptoms, which is rigidity and autonomic instability. Those are things that can actually hurt them. If they're repeating you, that's not going to hurt them. Or if they have a behavioral thing and they're trying to pull stuff out of their body and punch people, that's a problem. ECT is more effective than benzos, but benzos are just seen as a quicker, safer, kind of less side effects thing, which is basically just, if you typically can get a person in a reasonable state in 2 days and you just had to give them 6 to 8 doses of benzos, why would you send them somewhere to do 2 weeks of ECT kind of thing? And benzos are pretty effective. So the efficacy is all over the place, honestly. So they like to point out that like American studies are over 60% up to 100%, and then and you go to Asia and it goes down to 0%, and then it's an argument of, well, they're not doing good selection samples because benzos typically don't work real well if a person's been locked up or with catatonia for about 10 days or more. They don't beat placebo at that point. And the people who did the 200-person case series, turn that off. People did like a 200-person case series for consult liaison. They said, they had like an 80-90% success rate by just using benzos. So they work really well. They're super safe. They're fine. Basic strategies, you try your first benzo, you give it kind of 3-dose run is what I would recommend, and if you get nothing from it, you switch to the second benzo, give it a 3-dose run, and if you're already on your second dose and you're not sure anything's happening, you should probably be chasing ECT already, getting it set up, because that's what they're going to need. ECT works regardless if it's been 5 days, 10 days, 40 days for catatonia, so don't worry, it's really effective. If you're not really, in general, if you're not happy with where you're at day 4 or 5, just go ahead and start the ECT process, because it might take a little bit depending on where you are. There we go. Safety concerns. These are kind of the things you should think about, put in your note. Let the primary team know so that they take care of them properly. So dehydration and malnutrition, right? That can lead to kidney failure because you're not getting anything in. You get AKI, and then, electrolyte imbalance, and then you end up with multi-organ problems, heart attack, stuff going on. Immobility, right? If they're not moving, you've got problems with DVT, pulmonary embolisms, pressure ulcers, these kind of things, right? Just the person's not laying there, so they need to do DVT precautions, which, depending on how long it is and what's going on, right, that they could start using blood thinners at that point, and sit there and do the little SCVs or whatever they're called for their legs to keep squishing them to help blood flow out of their legs. Contractures, I don't know how somebody be in this situation for so long they'd get contractures, but I guess that happens, or used to happen. Dangerous behaviors, right? So if they got the agitation, negativism, excitability, impulsivity, that kind of thing. People don't know what they're doing, at that moment. They're kind of bizarre. If they're not really moving a lot, you try to give them food. Pneumonia from aspiration's a real risk. Urinary retention happens, or other times they just have urinary incontinence. It's the opposite, but urinary retention, UTI, sepsis, right? That's a problem. Cardiac arrhythmias, which I think actually a patient I've had had that happen to them. It was just like in that person's situation, it got some AFib randomly, got watched, did some basic just oral medications for a day, was fine, and didn't come back, but I think AFib was caused by it. So this is my version. Keep changing this. I deleted more today because I'm just like, this thing should not be that complicated, and it's ridiculous. So how do you treat it, catatonia? Just start with lorazepam. If that doesn't work, go to diazepam. If that doesn't work, shock them. Go to ECT. Basically, lorazepam is awesome because you can put it in an IV. You can stab them, right? You have your B52. You do it all the time. You do your Benadryl with your lorazepam and Haldol for acute agitated psychotic patients. So lorazepam's IM. And then you can do it as an oral. So it's like every version. It's just super easy. And all the benzos are just slight variations of the same drug. So basically, if the patient's scary, start with 1 milligram. If they're just super healthy and it's, you don't have any concerns, you can do 2 milligrams. This is basically your challenge dose at the beginning. You want to see if you have any kind of change in the next 30 minutes or so. So you should go check up on them at that point and see how they did 30 minutes after you take the shot. A good first round from this, I like. This is basically what the CNL folks did, who went through a couple hundred people over a decade. Is basically you do the challenge dose and then you do 2 Q3 hour follow-ups where you do that same dose. So if it was 1 milligram, you do 1 milligram 3 times in the first 6 hours, because it's time 0, 3 hours, 6 hours. You do 2 milligrams, then you give them 6 milligrams within the first 6 hours. And it's to see if you get a good resolution of a lot of the symptoms or if you get any benefit. And then after that, you're just doing daily adjustments. You can add 1 milligram or each day, or I guess 2 if you really felt like you weren't getting enough response and you really want to check more to see if it's helping. And you're adding that to each dose, so it's an equal spread throughout the day. You're not trying to vary it throughout the day. You're going to just make everything confusing and weird. So if you did 1 milligram 3 times a day, and then day 2 maybe you go up to 2 milligrams 3 times a day, and then day 3 you go 3 milligrams 3 times a day. It's totally fine. Again, 4 to 10 days to get them out of this situation. Typically, people take somewhere between 6 and 21 milligrams. It's split, so up to 7 milligrams 3 times a day, right? Or it'd be like 4 milligrams or 6 milligrams 4 times a day, or something up to 24. Some people, they've gone all the way up to 30 milligrams. It's totally fine. Diazepam, basically it's a 5-to-1 ratio of strength. So if roughly 5 milligrams of diazepam equals 1 milligram of lorazepam, give or take, right? So 5 and 10 are your starting dose, and then you're going to do a Q3 hour repeat, and then the same thing, except you're going to add 5 milligrams. So if you did 10 milligrams 3 times a day, then you have 15 milligrams 3 times a day, and then 20 milligrams 3 times a day. And if you get up to 100 milligrams, that's fine with that drug. So Treatment of catatonia when you're doing ECT, I don't really know a lot about this. This is just kind of what the books say. So it's a bilateral protocol with suprathreshold stimulus. So they don't do the unilateral for these folks. They go to both sides. And then suprathreshold means you're going beyond the seizure threshold. I don't know how super that means, if that's 20% or what. The typical course is 6 to 20 sessions, just like it is for everything you do for ECT. It's 3 times a week. In catatonia, almost everybody breaks by the second or the third session. So it's like an obvious end to it. And that's it. This is being recorded, so there are no questions. So take care, everybody.